Hello, my name is Lucas Martin. I'm going to be teaching about the cardiovascular section of the AEMT class. We're going to get started here shortly. We're going to cover a lot of stuff. This first section that we're going to discuss is going to be the anatomy of the cardiovascular system. If anybody has any questions, I'll make sure that you have my contact information, and I will be seeing you guys in class for some of the lab sessions, and hopefully if anything needs clarified, I'll be able to do that then. And also any questions can be directed to John, and if you just need anything, just let me know, and let's get started. So like I said, the first PowerPoint that we're going to discuss is going to be the anatomy of the cardiovascular system. We'll also talk about the electrical conduction of the heart. And then later on, we're going to discuss some common cardiovascular emergencies, basics of EKGs, ECG interpretation for beginners, and then we're going to get into some more advanced ECG interpretation. It's always important whenever you are thinking anything in terms of cardiovascular emergencies, you need to remember the anatomy. The anatomy of the heart and the entire cardiovascular system. Keeping this in mind is going to really help you determine what's going on with your patient. Without a good foundation of the anatomy of the cardiovascular system, it's really difficult for you to have a good idea of what's going on, what's really going on with your patient, and really comprehending or understanding what the issue with your patient is. So what makes up the cardiovascular system? In general, we do have three components, often referred to as the pipes, the pumps, and the pudding. So first we're going to discuss the pipes. Quite simply, the pipes are the vasculature of the body. You have arteries, veins, capillaries, miles and miles and miles of vasculature in the human body. Every amount of tissue in the body is supplied by some sort of blood vessel. Obviously, the blood vessel's purpose is to transport blood, nutrients, and proteins to the tissue, and then remove waste and build up acids and stuff like that from the system, taking it down to the kidneys to be excreted. Something that becomes pretty important whenever we start discussing the heart specifically in terms of heart attacks, myocardial infarctions. We need to consider a term that you'll hear called collateral circulation. Basically what collateral circulation means can be kind of used hand in hand with anastomosis. Basically, in the heart as well as throughout the body, you do have sort of a backup vascular system in case you do have damage or injury to a certain blood vessel. Collateral circulation means that you do have a blood vessel that runs with a given vessel and allows you to kind of have a backup that runs right beside it and can take over the workload if the main vessel is compromised. For example, in a myocardial infarction, which we'll get into later, is where you have a clogged clot in one of the coronary arteries. And most of the coronary arteries do have anastomose, where there is a vessel running alongside the other vessel, and after years and years of plaque buildup, you do have a kind of a backup that can kind of take over the workload as that vessel is clotted off with plaque and buildup. And we'll get into that as time goes on. There is a lot to discuss in terms of the cardiovascular system and just the anatomy of the cardiovascular system. We could spend a whole class session talking about just the vessels, but we are very short on time, so we're going to have to move on. Is the blood. You have the blood in the human body with multiple components. Predominantly, the main components in the blood are your red blood cells, your white blood cells and platelets, and the plasma. Plasma is the, in essence, the volume of what gives your blood volume. It's about 50% of the blood volume. And then the rest is made up with white blood cells, platelets, red blood cells. Bonus question here. I'll just give you the answer to it. Red blood cell lifespan in the normal human adult is about 120 days. So every 120 days, the red blood cells die naturally through apoptosis and are regenerated. Excuse me. The reason for red blood cells death, as the red blood cells, they have to pass through the smallest capillaries in the body, and these are very small. You think about how many small, tiny capillaries are in the tips of your fingers, for example. You have to have red blood cells that pass even through those. They can get as small as 7.5 microns, which is an extremely small measurement. And then you take the average size of the red blood cell at 10 microns. So as they're trying to pass through these capillaries, they're having to bend, and they bend in half just to fit through there. So as you think about anything, a piece of plastic that you bend in half over and over again as the red blood cell passes through the human body, and over time it gets weak. So the more that happens, the weaker it gets, and they do have the natural death process of the cell, and are regenerated over time. There are a lot of functions of blood. Obviously, the big ones are transportation, oxygen-rich. Obviously, tissue requires oxygen for life, and so our red blood cells transport the oxygen through the use of hemoglobin throughout the system to keep oxygen to all the tissue. The blood also regulates pH and the water content of fluids in the vascular space and in the spaces outside the blood vessels. And then protection. So the blood has clotting mechanisms, antibodies in the white blood cells, interferons. Phagocytosis is a process by which blood cells, white blood cells, consume foreign bodies and prevent infection, as well as many others. There's a lot of functions of blood in the human body. Common lab values. Okay, continuing on, we're going to look at just a few more lab values here. If you look at the ones listed, the CPK is a pretty common lab value that will be looked at in patients that they're trying to determine if there's any type of cardiac ischemia. You see the normal value there. CKMB is just a subunit of the CPK, creatinine phosphokinase. The CKMBs, these are just two labs here that are generally used. It's a enzyme that's released in cardiac skeletal muscle whenever there's any type of ischemia. Troponin is the most specific lab value that's looked at whenever dealing with cardiac ischemia. Troponin's not very commonly found in most skeletal muscle. It's pretty specific to the myocardium. So whenever there's damage, if you'll remember when we were talking about the way that muscle contraction occurs, whenever there is damage to the cardiac muscle, that's the only time that troponin is going to be released. So in the normal healthy adult, the troponin level should be 0.00. Anytime there's an troponin above the level that you see here, it's abnormal due to some type of ischemia. The BNP stands for B-type natriuretic peptide. It's a very useful lab value in dealing with heart failure, acute heart failure. What it doesn't do is determine the cause of the heart failure. It just is able to tell you that there is some type of mechanism causing decreased cardiac output for whatever reason. The value that you see here is commonly tested in patients with some type of cardiac dysfunction. It's not very useful in patients with chronic heart failure because they may have a chronically elevated BNP. It is very useful in determining. Moving on, talking about the cardiovascular anatomy, this is the aspect that we're going to be focusing most of our time on. This is the pump. So the heart is really what we're going to spend the majority of our time talking about. Obviously, the mechanism or the purpose of the heart is to pump blood from the lungs into the heart, from the heart out to the system. So all that vasculature that we talked about has to be supplied with oxygenated blood, and that's the heart's job. So from the body, the blood goes from the superior and inferior vena cava into the right atrium, into the right ventricle, where it is pumped into the lungs. And from the lungs, it goes into the left atrium, where it's pumped down into the left ventricle, which then pumps it back out into the body. Just a side note here, this will come into play a little bit later. Talking about the coronary anatomy, it's important to remember that the left atrium do have two, the left and right atrium do have two sacs that just sit on the anterior side called the auricles. Auricles are basically just little pouches of tissue that increase the size of the atrial filling capacity. You have one on each side. And we'll look at some pictures of those in the next couple slides here. Just think about the fact that the ventricles are quite a bit larger than both atria. So to increase the filling size, these pouches are there to just increase the amount of atrial kick when filling the ventricle. Looking at the heart's position in the thorax, you can see here the aorta just arises. The apex of the aorta sits right the first set of ribs and extends down. The furthest part down usually rises or ends down at the level of the fifth intercostal space, where you'll find the apex of the left ventricle. It usually sits basically just right behind the sternum in the cavity called the mediastinum. The heart points down and to the left. The largest portion of the myocardium is pointing down and towards the left side of the body. The heart weighs about 350 grams, which is about a pound. This is just an example of a, it's not a very good picture there, but you can kind of see the outline of the heart on the average chest x-ray of an adult male. You can see it here sitting in the mediastinum. You can notice here that the heart does kind of sit anterior. It's not just straight up and down, which is kind of hard to recognize in most of the pictures or graphic representations of the heart. It is important to remember, though, that it does kind of sit anterior, moves from posterior to anterior in the chest as it goes down towards the large part of the left ventricle. This is another view of some chest x-rays. This is from the frontal view. You see here the sternum, the large left ventricle, how the left ventricle sits right onto the diaphragm. And then you can see the apex of the aorta up here on these first set of ribs. This is the lateral view, so the closest side would be the patient's right arm. And again, notice this left ventricle does sit right on top of the diaphragm, and then you have the anterior movement of the heart. All right, we'll start talking about the layers of the heart from the outside in. You see here, this is just a cadaver picture of the average human heart with the lungs removed. Remember that the lungs would sit in here. Everything's tucked in pretty tightly if this patient were alive. Obviously, these lungs are deflated. There's no air in them, so it's kind of not really an accurate picture of what we see in the adult male. See here, you do have the you're able to see the ventricles and the atria in the heart here. It's kind of hard to tell where one stops and the next one starts, but just recognize that you do have the two atria up here, the right and the left, and the two ventricles, the right and the left. So the muscle of the heart, the myocardium, has layers inside and outside of it. The muscles referred to as the myocardium. On the outside layer, you have what's called the epicardium, which includes both layers of the pericardium. And then on the inside, you have the endocardium, which is the smooth endothelial tissue that lines the chambers of the heart. So on the very outside, you have what's called the fibrous pericardium. It's called that because it's a very sinewy structure that forms a tight bond around the heart. And then you have two layers of the serous pericardium, a parietal and visceral layer. And this is what makes up the epicardium. Between these layers, you do have a sac, a fluid-filled sac. There's a small amount of fluid that's in this area that provides lubrication for the heart's pumping mechanism. It's very interesting whenever you can run into patients that have a decrease in this fluid. Anytime there's a decrease, it's going to cause friction, and you can hear friction rub whenever they have a lack of this fluid, and there's various pathologies that can cause that. On the flip side, you can run into problems as well if there's an increase in this fluid, because this can inhibit the pumping mechanism of the heart, and we'll get into that in more detail later on. Do have a representation here of how the pericardium sits around the heart. Like I said, it's a fluid-filled sac, and it just molds to the heart. And you can see your layers here. The visceral layer of the pericardium sitting directly on top of the myocardium, and then a fluid-filled sac between the parietal and visceral layers. Usually about, in the average adult, there's anywhere from 25 to 50 milliliters of that pericardial fluid that should be in there. So any decrease or increase of that is abnormal. Talk about the valves that are in the heart. There's 4 valves that are important that we'll discuss here. Separating the right atrium and the right ventricle, you have the tricuspid valve. And we'll get into some representations of that here in the next couple slides. Separating the right ventricle from the pulmonary trunk is the pulmonary semilunar valve. and then the mitral valve separates the left atrium and the left ventricle, and then the aortic valve separates the left ventricle from the aorta. Notice here that it says that there's 3 tricuspid valves and 1 bicuspid valve. What that means is the 3 of the valves have 3 flaps on them, or 3 folds of tissue that create the valve, and then the bicuspid valve, or the mitral valve, only has 2 cusps on it. And we'll look at some pictures of that. Changing tune here. Real briefly, we'll talk about the differences in fetal anatomy from the normal human adult anatomy. Obviously, there are some changes in the fetus in their coronary circulation, because they don't have the same mechanism of blood flow as a live human. The fetus actually receives the oxygenated blood through the umbilical cord, so blood is actually shunted through the 2 atria from right to left. There's what's called the foramen ovale connects the 2 atria, and then once the live birth occurs, this closes within the first few breaths in the normal neonate. If it doesn't close, you can have some issues that arise from that, from poor oxygenation. The fossa ovalis is what is left behind whenever it occurs. The pulmonary trunk has pretty high resistance because the lungs are filled with fluid in the fetus. The ductus arteriosus is going to shunt blood from the aorta, and it also closes off after birth, within the first few breaths of birth, and leaves what's called the ligamentum arteriosum, which is there into adulthood. Interesting to note, you do see occasionally you'll see problems with the ligamentum arteriosum in high-speed mechanism of injury accidents or quick stop accidents. You can have a tearing of the ligamentum arteriosum. This is, remember, it's basically a connection. It goes right into the apex of the aorta. So anytime you have a tear here, it's a very life-threatening injury. If you remember earlier on, we talked how the blood flow in the body, blood circulates about once every minute. So all the blood in your body passes by a single point in about a minute. So if you have a hole in one of the largest vessels in the body, and all the blood's able to be removed from there in about a minute, obviously this is a very lethal injury. Again, this is just the changes that you have with prenatal fetuses. I wouldn't spend too much time worrying about this stuff. It's not very not something that is really necessary to have mastered. It's more of a good to know type of thing. So just kind of keep this in the back of your mind. All right, so here we have a representation of the valves. We're back to talking about the adults here. You can see, remember we talked there was 4 valves that separate the ventricles from the atria, and then the ventricles from the arteries that they supply. So the position of the valves here. Here we have our first one that we talked about. This is going to be your tricuspid valve. You have the separating the right atrium from the right ventricle. Once we get into the right ventricle here, we're going to go and we have the pulmonary semilunar valve, which is separating this right ventricle from the pulmonary arteries. In the left atria and left ventricle, we have separating the mitral valve, and then the mitral valve into the left ventricle. And then you can't really see it here, but it's right behind here. You have the aortic semilunar valve that separates this big left ventricle from the aorta. So if you note here, and I got a better picture of it on the next slide here, but you can kind of see what you have in these 2 valves that separate the atria from the ventricles. You do have some little strings of tissue here that connect the valve into the ventricle. These are called chordae tendineae. Down here, connecting the chordae tendineae to the wall of the heart are the trabeculae carinae. What these do here is they keep this valve from prolapsing. They make sure that the valve stays a one-way valve. So I'm sure you guys have heard of somebody having a prolapsed heart valve. What actually happens is these chordae tendineae get weak, and as the right or left ventricle pumps, way more common in the left ventricle. You really don't see a lot of tricuspid valve prolapse, but you hear of mitral valve prolapse pretty often, especially in patients with high blood pressure. Over time, these chordae tendineae get weak, and the papillary muscles that actually contract and keep these valves taut get weaker over time as well, and allow this valve to actually prolapse into the atria. The better picture here, a real life representation, the chordae tendineae preventing prolapse of the valve into the atria. This is what this is right here. You have the trabeculae coronae, which are the connection here to the papillary muscles. So as the ventricle contracts, these papillary muscles also contract. This puts tension on the valve and keeps it from being pushed up into the atria. It keeps that opening closed between the atria and the ventricles, so blood doesn't flow back from the ventricle into the atria, and it pumps where it's supposed to go. I think I already mentioned here once, but we'll mention it again. This comes into play a lot whenever we start getting into the EKG interpretation. Just keep in mind that the left ventricle, the muscular wall, is much thicker on the left side than it is on the right side. The reason for this is that there's much more resistance. You have systemic vascular resistance in the left ventricle. There's a much further distance that the left ventricle has to pump to get blood out into the system, whereas the right ventricle, all it has to do is pump into the lungs. So it's a much lower pressure than the left ventricle. There is a large septum here that separates the two ventricles, and that'll come into play a lot more when we start talking about 12-lead EKG interpretation. Also, remember that the atria are very thin-walled because the pumping mechanism of the atria is relatively weak in comparison to the ventricles. Reason being is that the ventricular filling is assisted by gravity, so there's very little effort by the atria to actually pump blood further down into the ventricles. Okay, so real quick, we'll talk about this is going to come into play when we start talking about ischemia and infarctions in our 12-lead EKGs. This is the cardiac circulation. So as we've already discussed, the heart is just a large muscle. It's just like any other muscle. It requires blood to function. It has to have a continuous supply of oxygenated blood, just like any other muscle does in the human body. So the heart has its own coronary circulation that provides itself with blood and removes byproducts and waste, just like any other muscle. The coronary arteries rise just below the aorta in what's called the aorta, and we'll look at pictures of that shortly. The coronary perfusion occurs during rest or diastole. Reason being is that during systole, or during the pumping motion, the pressure in the heart is too high, and it actually, during the pumping motion, the coronary arteries are compressed because of that high pressure that's occurring in the ventricles. So the coronary vasculature run along sulci down the surface of the heart, just below the surface of the heart. And if you look here, we have a representation of the common coronary arteries. Here we have our coronary sinus, just below the aorta where all the coronary vasculature originates. We have two main, on the anterior side of the heart, we have two main arteries. We have the left main coronary artery, and we have the right coronary artery. The left main coronary artery comes down and supplies a significant portion of the anterior side of the heart. The left main branches off into the left anterior descending artery, which I'm not seeing identified on this picture, but this one, let's see, yeah, this one right here You have a circumflex artery that branches off the LAD and supplies the, usually, and remember that this is in the average person. People's coronary circulation can vary, and there's, so there you do have variation from person to person on what coronary artery supplies what part of the heart. But in general, the circumflex artery is going to supply the lateral side of this left ventricle. The right coronary artery comes down and supplies a significant portion of the right side of the heart, including the right atrium and the right ventricle. You see that you do have a marginal branch that wraps around to the posterior side and the right side as well. Note that you see this, don't see it on this particular picture, but you'll hear often reference to the diagonal artery. What this is a generalized term of a smaller coronary artery that branches off of a larger one. So you see these small arteries that don't have any names, and you can often hear those referred to as a diagonal to the whatever artery is connected to. This is a picture of the posterior side of the heart. There is some variance in people's coronary circulation as to what supplies the left or the posterior side of the heart. Occasionally you'll have a right coronary artery that's quite large, and it wraps all the way down the right side of the heart and then comes up the posterior side and supplies the majority of the posterior side as well. Or you can have a variance of where you have a circumflex artery that comes around the backside and branches off and supplies the posterior side as well. So here you see that your circumflex artery coming off of remember the other side where the left anterior descending was, it comes back here, and you have your marginal artery as well, which branches off of the left main coronary artery. Or just remember that occasionally you can have a right coronary artery that branches down and then comes all the way up and supplies this area of the myocardium as well. We'll talk about heart sounds very generally. We're not going to get into very much of the heart sounds that you hear in pathological patients. Just the normal, what quote unquote normal heart sounds you should normally hear in the average patient. The normal heart sounds are called S1 and S2. S1 is the closing of the atrioventricular valves, or the valves that separate the atria from the ventricles. This is your mitral and tricuspid valves. This heart sound occurs at the start of ventricular systole. And then the S2 is the closing of the semilunar valves, or the aortic and pulmonary semilunar valves, at the end of ventricular systole. Anytime you hear a heart murmur, you hear somebody refer to a heart murmur, this is just an alteration in the sound of blood flow. A lot of people walk around every day with a heart murmur. It can be normal for them, or it can also be abnormal, associated with some type of pathology as well. There's 4 general places that you're going to auscultate heart sounds depending on what you're trying to listen for. You see these listed here. You can go over those as you want to. You can also go to this website that I have linked in here, and there's some really good audio of heart sounds, and they have some abnormal heart sounds as well. We're not going to get into a lot of the murmurs and what those murmurs sound like, but just you know, if you're interested, you can go to this website, and it's got a lot of the gallops and clicks that you can hear in abnormal heart sounds. So generally the best place that you're going to listen to if you're just trying to listen, for example, an apical pulse, is going to be at the 5th intercostal space in the midclavicular line. This is generally where the apex of the ventricle ends, and it's going to be the loudest place that you can hear heart tones. But then you also have these other places that you can listen whenever you're trying to listen to a particular valve. So not really something that's very practical. Honestly, you know, we're not listening to heart tones very often, unless it's in a patient that we're trying to determine if they have a heartbeat or not. But on your general run-of-the-mill EMS call, it's not really something that we're going to get too detailed into. Okay, so we're going to talk about the cardiac cycle and what's actually occurring whenever we have our heartbeat. So there's two parts of the cardiac cycle, as I already mentioned, diastole and systole. Diastole is the rest phase, systole is the actual pumping phase. We'll talk about the ejection fraction, stroke volume, preload, cardiac contrality, and afterload, and then cardiac output. So we're going to look at these. And you see this representation over here of what's actually occurring in the diastole phase and the systolic phase. So during diastole is our ventricular filling period. This is when the atria are dropping their blood down to fill the ventricles, and then our systole phase, where our ventricles are actually pumping, and they're pumping blood to the lungs and the body. All right, stroke volume is just a measurement of the milliliters of blood that are being pumped out of the ventricles in one single heartbeat. The way you find this is not really that important, since this isn't something that we can just figure up whenever we're riding in an ambulance, but just good to know. The way that you do figure it is taking the end diastolic volume and subtracting the end systolic volume. That's the amount of blood that was in there before it pumped and the amount of blood that is left over afterwards. Cardiac output is you take your stroke volume and multiply it by the heart rate. This is the amount of blood that's being pumped out of the heart in a minute. It's usually around 5.25 liters per minute in the typical adult male. And if you remember, that's pretty dang close to our entire amount of blood in the body. So like we said, the entire blood flow, the entire blood volume circulates the body in 1 minute. Our ejection fraction is a percentage of blood that's pumped out of the ventricles in a single stroke of the heartbeat. I believe I mentioned earlier, I'm not sure if I'd mentioned this yet or not, but in the normal adult, your ejection fraction is not going to be 100%. Your ventricles aren't pumping out 100% of the blood that's in them in a given heartbeat. Typically, your ejection fraction is 55 to 70%, so you still have anywhere from 45 to 30% of the blood that was in the ventricles left in there after they've pumped. Your ejection fraction is found by taking the stroke volume divided by the end diastolic volume and multiplying by 100. As I said, not something we're going to be figuring up. This is something that you have to have an echocardiogram to determine what your ejection fraction is, so it's not really practical, but it is good to know. All right, I'm not sure if you guys are familiar with Frank Starling's law right now. I'm not sure if that's something that's taught in EMT class or anything like that, so we're going to go over that. It's a pretty important mechanism to be familiar with. Starling's mechanism, what it is, basically Starling's law says that the greater the stretch of the heart, the more your stroke volume is going to be to a certain extent. So the more the heart is stretched, or the more blood that is pumped into it, the harder the heart is going to contract up to a certain extent. If you get to a point where the muscle is hypertrophied and it becomes floppy, your stroke volume is actually going to decrease because that muscle loses its contractility. But to a certain extent, the harder or the more stretched, the harder the squish. So this law was discovered back in 1919. It's referred to as Starling's law, or sometimes you'll hear it as Frank Starling's law. Most people think that Frank Starling was the guy's name. It is actually Otto Frank and Dr. Starling. I don't remember his first name. So Otto Frank and whatever Starling is two different people, and they are the ones that discovered this mechanism. So putting it together, there's three things that affect Frank Starling's law. That's going to be your preload, the contractility, and the afterload. So basically what these are, preload is the amount of volume that is provided into the ventricles by the atria. It's just the number of milliliters that are pumped into the ventricles before they contract. The contractility is the amount of squish that you have, how hard the ventricles contract, and the afterload is the pressure that the ventricles have to pump against to get the blood where it's going. It's pretty important to remember that these values can be affected, and they can be affected by things that we do. So it's important to whenever we start talking about some of the medications that you guys are going to be given for cardiac conditions, you need to know what you're given and how these are going to be altered by what we're doing. So the question is, can these be altered? It's a very resounding yes. Preload is going to be affected anytime there's a decrease in blood volume. Contractility, there's a lot of medications, not necessarily that we give, but medications that can affect contractility, such as digitalis is a big one. And then afterload is something that we do affect with a lot of meds that we give, which is the pressure that the ventricles are pumping against. Contractility is increased with higher calcium inflow during the action potential, increased with positive inotropic agents such as epinephrine, levophed, digitalis, etc. And then afterload is going to be increased with hypertension, atherosclerosis, and afterload is also decreased with any beta blockers that we might give, or nitroglycerin as well. As already stated, there's three controls. The inotrope refers to the contractile force of the heart. Dromotrope refers to the speed of conduction, and then chronotrope refers to the heart rate. So we do have medications that can affect all three of these things, and so it's important to remember that we can have an effect on these sometimes if we don't know what we're doing, not for the better. All right, we're going to talk about the electrophysiology of the cardiac conductive system. There's four properties that we need to be familiar with. That's excitability, conductivity, automaticity, and contractility. And we'll get into those in more detail. Automaticity is the referring to the pacemaker cells, not just the contracting cells in the myocardium, but the pacemaker cells that keep us with a heartbeat. Ions are positively or negatively charged molecules, and we'll get into the most important ions that we need to be familiar with here shortly. Just remember right now that the main positively charged ion in the body is sodium. The main negatively charged ion in the body is chloride. Other ions in the body include potassium and calcium, and we'll talk about why those are important. Bioelectricity is created by the movement of ions through a semi-permeable membrane. This occurs in all cells throughout the body, but we're talking specifically about cardiac cells right now. The main extracellular ion is sodium, and the main intracellular ion is potassium. If you'll remember that every cell has a membrane around it, and okay, so if you guys remember, we've talked about, you have an extracellular space around every cell in the body. So you have ions that are inside and outside of the cell. So as we already stated, naturally the most common ion on the inside of the cell is potassium, whereas the most common ion outside the cell is sodium. And the change of these, or the reversal of these ions, is what stimulates electricity, or creates a small, minute amount of electricity. So after this occurs, you do have to have a return to homeostasis, to where naturally the potassium is back on the inside of the cell and sodium's on the outside. So what happens is you have a massive influx of sodium, you have a passive outflux or efflux of potassium, and then it has to be returned to normal. So you have millions and millions of small, tiny sodium-potassium pumps that act as kind of a gatekeeper on every cell, and they sit there and they pump potassium back into the cell, and they pump sodium out. So, and we'll discuss this in more detail. We're going to, as we talk about the action potential of the pacemaker cells, and hopefully that'll make a little more sense. So this is a representation of the action potential that causes our heartbeat. So I have a better picture of it on the next slide. Real quick, we'll just talk about what happens in each phase of the action potential, what really creates our heartbeat. So you see here we have 4 phases. There's something happening in all of these phases that causes our electrical stimulus to create the pacemaker every time our heart beats. So every time our heart is beating right now, we have this action potential that stimulates the heart to beat. Note here on the side that you do have a threshold potential. So what happens as we get up to this threshold potential is we have below the threshold potential, and this is just in our pacemaker cell, we have a passive influx of sodium, and we're stimulating a tiny amount of energy until we get to our threshold potential. Once that threshold potential is reached at negative 60 millivolts for our pacemaker cells, we have the gates open and there's a massive influx of sodium. So as this happens, we run into phase 0. So phase 0 is our depolarization phase, where sodium massively enters the pacemaker cell and causes our electrical stimulus to occur. We peak out at phase 1, and at phase 1 we have a slow potassium outflux, which is our attempt of returning to homeostasis or getting back to our baseline. At phase 2, we're still releasing some of our potassium, but we have a active efflux of potassium. So we're kicking out our potassium, and we're trying to return to homeostasis. So once we get to phase 3, we're actively kicking everything out to try and get back to our negative 60 millivolts, or negative, and I apologize, I believe I misspoke. So our natural, what we're naturally sitting at is going to be negative 90 millivolts. Once our pacemaker cell gets up to negative 60 millivolts is when our action potential occurs. So as that sodium enters the cell passively, we'll get up to that threshold limit, and that's when our stimulus begins. A little better picture of it that'll help you understand a little more. So we have our phase 0, and remember, and this one doesn't show phase 4, but phase 4 is down here with our passive sodium influx. Once we hit phase 0, we have our active sodium influx into the cell. That's when depolarization occurs. We get our slow potassium efflux and our fast potassium efflux during repolarization. So right here between phase 1 and phase 2, we have a influx of calcium, which is what is going to actually promote contraction of the myocyte. We'll look at that a little closer here. If you notice here, and we already talked about this a little bit, we have our this is the example of a individual myocyte, and the contraction of the myocyte. So we're not going to get into talking specifically about the bands of the muscle and the muscle fibers and such, but we'll real basically just keep in mind that calcium works as a gatekeeper. Once that calcium fits into the lock, we have a contraction of the muscle. There's a tensioning of the fibers that causes the myocyte to contract. So remember, we talked about the enzyme troponin. This is the example of our troponin right here. So anytime there's damage to that damage to that myocyte, troponin is going to be released into the bloodstream, and which is a problem. We've already talked about, or we should have by this point already talked about, the autonomic control of the heart, but we'll get into that in a little detail here, so we can kind of discuss how this actually plays in, specifically considering our cardiac muscle. So we have 2 parts of the autonomic nervous system. Remember, the difference between our somatic nervous system and autonomic is that our somatic is under conscious control. The autonomic is regulated by itself. We don't have any conscious control of the autonomic nervous system.
We have two parts of the autonomic nervous system. If you guys remember, we have the parasympathetic and sympathetic. So real basically here, we have our two sides, and we have our little heart down here, and we have the turtle tugging on the parasympathetic side, and our rabbit is tearing at the sympathetic side. Our sympathetic side wants to speed up the heart rate. It wants to increase contractility. It wants to speed conduction through the AV node. Our parasympathetic side is trying to rest, and remember, parasympathetic is rest and digest. It wants to slow everything down, wants to decrease contractility, slow the conduction through the AV node. You have two main chemical messengers, one for the parasympathetic and one for the sympathetic. The main chemical messenger on the parasympathetic side is acetylcholine, and the sympathetic side is epinephrine. And we'll get into that more as we talk about the medications that we're given for our cardiac medications that you guys are going to be able to give, and discuss how those come into play with the enzyme acetylcholinesterase and how that works with acetylcholine. My compadre here is telling me to slow down, so I'll try here. If you guys remember, I'll give you my phone number. If you guys have any questions, you're more than welcome to call me. I will note that this is the second time that I've done this lecture, because the first time it didn't record when I thought it was, so that's why I'm going a little fast. All right, it's important to recall that the autonomic nervous system doesn't establish a heart rate. Excuse me. The autonomic nervous system can't create any type of stimulus that creates a heart rhythm or a heart rate, a heartbeat. All it does is regulate the strength of it and the speed of it. It can alter the heart rhythm, but it can't create one. It's also important to remember, as we talk about our cardiac medications, that the parasympathetic side of the system doesn't have any control over the ventricles. So anything that we give that affects the autonomic nervous system on the parasympathetic side, one example is atropine. It's important to remember that it's not going to stimulate the ventricles. It only affects the up to the AV node. And the sympathetic side does have control of the ventricles. All right, so now we're going to get into talking about some of our stuff that's going to come into play a lot more as we begin talking about our EKGs, the conductive system of the heart. So as I already mentioned, the myocardium has to be stimulated electrically to contract. So there has to be an electrical system that innervates all of the muscle tissue to stimulate a contraction. So there's several components to this electrical conductive system, and we're going to have to get into those, because as we look at our EKGs, it'll come into play that we're able to determine certain things by what we see on it. And it's important to understand what you're really looking at whenever we start interpreting our EKGs, and to have an understanding of what's going on in the heart based on what we're looking at on the EKG. So the SA node is where, and remember, right now we're just talking about the healthy adult with no pathology. It's everything's normal, quote unquote, for this person. So the healthy adult has a pacemaker, a small clump of pacemaker cells sitting up in the right atrium. These are referred to as the SA node or the sinoatrial node. What happens here, if you guys remember, we talked about our action potential and the threshold limit value and everything. This is where this comes into play in our SA node here. So we're continuously receiving these electrical impulses in the SA node, and those are generated in this clump of cells. They act as the pacemaker for the heart, and they provide electrical stimulation that runs down and causes our heartbeat, our entire heartbeat. All that arises up here in this clump of cells in the right atrium. So remember that our normal heart rate is established by the SA node. Since we have this action potential, our pacemaker site providing a stimulus for our heart rate, it has to travel out of the SA node and get all the way throughout the heart, including the other atrium and the ventricles. It has to provide that electrical stimulus so that the entire heart contracts when it's supposed to. So what happens is we have some wiring that runs from this SA node, travels all the way down to the bottom of the apex of the left ventricle, and we'll talk about what that wiring looks like and why it's important here. So once it leaves the SA node, it leaves through 4 internodal pathways that travel through, 3 of them through the right atrium, and then you have 1 that leaves and goes over to the left atrium. So these stimulate the atria to contract or depolarize. Remember that what we're talking about here is just the electrical system. So what I'm indicating is that, you know, we're providing this electrical stimulus, and it has to spread throughout the entire atria to cause that atria to contract. So once it gets through the atria, we come to another clump of tissue down here known as the AV node. What the AV node is just a small clump of tissue. Remember, these are different lengths, so what this does is provides a meeting spot for all these stimuli. They all meet up right here, and they want to travel together down to innervate the ventricles. So once it passes through the AV node, we go through the AV junction and then down into the bundle of His. Well, the bundle of His is just the wiring that goes through the atrioventricular septum and provides the stimulus into the ventricles. After the bundle of His, we're going to branch off. We have 2 bundle branches. We have a left bundle branch here and a right bundle branch here. The left bundle branch stimulates the left ventricle. The right bundle branch stimulates the right ventricle. At the very basic units of the bundle branches, we have what are called Purkinje fibers. The Purkinje fibers, once the stimulus reaches them, this is what is going to stimulate the ventricles to contract. As they depolarize down in the very basic of the Purkinje fibers, the ventricles receive that stimulus and begin their depolarization and their contraction. So as I already mentioned, the SA node is naturally leaky to sodium. So there's always going to be sodium leaking into that SA node. This is what, in essence, causes the SA node to be the pacemaker. The other cells in the conduction system have to receive stimulus from the next cell. As the stimulus travels down, they get their stimulus from the previous cell and the previous cell and so on. So the SA node doesn't have anything above it to provide that stimulus. So it has this natural tendency to leak sodium, and so it's always creating electricity in the normal person. We want it to anyway. It's always creating that stimulus because it's naturally leaky to sodium, so there's always sodium leaking those cells. Not really important to remember, but just for you guys to know, there is a name for these internodal pathways. On the left-hand side here, we have, or the posterior side here, we have Thorell's bundle. We have the Bachmann bundle over yonder, right here, and then the Winky-Bach bundle. And all these come down and they meet at the AV node. Looking at the speed of conduction here, in the event that there is some type of pathology and the SA node is unable to provide pacemaker responsibilities, hopefully we have another pacemaker that comes up. The SA node is normal beats or normal speed that it operates at is 60 to 100 beats a minute. If it's not pacemaking, hopefully we're going to have one of these internodal pathways. There will be arrhythmogenic tissue that takes over pacemaker responsibilities, and it can provide a pacemaker at a rate that's fairly close to the SA node. If not, then the AV node will hopefully take over conduction, but it's not really able to keep up as much as the SA node is because it's not naturally a pacemaker. So it's only going to, in general, give us about 40 to beats a minute. If it's unable to maintain pacemaker responsibilities, it's going to travel down, and at some point along these bundle branches or the Purkinje fibers, we're going to have a pacemaker, and it's only going to give us about 20 to 40 beats a minute. So if you notice, with this kind of a system of backups, it's designed to maintain life, but it's not able to provide the same, do as good of a job as the SA node does. Really, the only good pacemaker is up there in the SA node. Any variance of that is usually an issue. The if we look at the speed of conduction of the tissue here, we notice that the myocardium, the speed of conduction through that the system there is about 40 to 80 centimeters per second, so pretty quick. The Purkinje cells, they depolarize at a rate of about 180 centimeters per second, which is even faster. Now, if you look here, what's interesting to note, the AV node is really quite slow. The conduction rate is only moving at about 2 to 3 centimeters a second. The reason for that is that we want to have a pause between the depolarization of the atria and the depolarization of the ventricles. So what the AV node does is provides a little a pause just for a fraction of a second to allow the atria to depolarize before the ventricles do. If that impulse traveled down without slowing down, what we would in essence have is depolarization of the ventricles and the atria at basically the same time. They're going to be pumping against each other, and pumping is not going to be effective. So that's why we have the AV node slow everything down for a split second, and then allow that stimulus to travel down and depolarize the ventricles after the atria have already been depolarized. As I said here, we do have 4 arrhythmogenic zones. Our normal arrhythmogenic zone is going to be our sinus node here. And then, as we said, if it doesn't handle pacemaker responsibilities, we'll have an atrial pacemaker that takes over. It's not doing as good of a job. And then if it fails to fire, then we have an AV node, AV zone, arrhythmogenic zone that's going to take over. And then if it fails to fire, the ventricular arrhythmogenic zone is going to take over. Each of these is less effective than the last. So the ventricular zone of arrhythmogenesis is really not very effective at pumping, or not very effective at being a pacemaker. So it really isn't able to establish a good heart rate, and there's going to be problems associated with that. Okay. So we're going to start getting into some of the stuff that's going to really play into our EKG interpretation here, and how it relates to what's actually going on in the heart. So it's important to remember every single piece of the conduction system has its own tiny stimulus of electricity. So we have whenever we add all those up, we can kind of look at the direction or mean flow of electricity and determine what we call vectors. So what a vector is just a diagrammatic way of showing the strength and the direction of an electrical impulse. And we'll be able to determine the strength and direction of those impulses by looking at our EKG. So right now, the only thing that you really got to keep in mind is that our vector is just the average flow of electricity, its direction and strength. And remember that vectors can either compound and create a stronger impulse, or they can cancel each other out. So look at our example here. We have an example of a vector of the same strength traveling in complete opposite directions. So those are going to equal each other out, and they won't have any deflection. If we have a vector that's traveling, 2 vectors that are traveling in the same place, and what I mean when I say this, just the impulse from 2 cells or a clump of cells traveling in the same direction, those vectors are going to increase each other's strength and create a stronger deflection. And likewise, if we have 2 that are running kind of equal but opposite direction, they're gonna go to the average. So we have one here, the vector of 2 going this way and 2 going that way, and they end up going to 3 in the middle, or the average direction of which way they're going. This is what I mean whenever I'm talking about the mean flow. So remember, every little myocyte and conductive cell in the tissue here has its own vector. They all have, they're all depolarizing in a certain direction, and they make an electrical stimulus in one direction or the other. The overall average of the vectors in this plane, in the frontal plane, should be pointing down and to the left. So it kind of goes up here from the right arm and down here to the left. This is going to be the average flow or average direction of electricity's path through the heart. If you remember how our path of stimulus goes, you remember it starts up here and then it works its way down this way, right? So that's kind of the average path of flow of electricity, and this comes into play as we talk about our vectors in our EKG leads. So whenever we're talking about our EKG leads, and whenever I say a lead is what we're actually looking at on our monitor. We have a lead 1, lead 2, lead 3, and we'll get into those in more detail later. And then the difference between a lead and an electrode, lead is using 2 electrodes and looking at what's between them. An electrode is just the single patch on a certain place on a patient's body. So if we have a vector or electricity that's moving towards an electrode, or a single patch on somebody, that's going to be deflected as a positive wave. Likewise, if we have electricity that's moving away from an electrode, it's going to be represented as a negative wave on our EKG. And if we have a electricity that's running perpendicular to our electrode, then it's going to deflect as an isoelectric or equiphasic wave that runs up and down the same distance. So on our EKG, we can have waves that are positive, we can have waves that are negative, and we can have waves that are isoelectric. So in here we have an example of what a positive wave looks like, what a negative wave looks like, and an isoelectric wave. Whenever we look at our EKG, each lead is just a picture from a different direction. So we have all these cameras that are around the heart, and our what we're actually printing off on our EKG is a representation of those pictures. So each picture is looking at it from a different direction. So if we have a camera that's looking from the bottom left and looking up towards the top right, we would expect that our electricity is moving towards this camera. So it's moving towards this electrode that's down here. So what would our wave be, negative or positive, if it was moving towards this camera? It's going to be moving positive because this is the mean flow of electricity to the left. So remember that, and it'll come into play as we get more into the EKGs. Stepping back, just a little general information on EKGs here. To be honest, this is a common question that I get whenever I'm teaching this class, so I'm going to go ahead and just put that question out right now. Seems like everybody wants to know why sometimes you see it as ECG and sometimes you see it as EKG. So we'll just go ahead and tell you the EKG was developed by a guy in Germany by the name of Dr. Wilhelm Einthoven. You see here, this is a picture of the first EKG machine. He's got 3 buckets of salt water here, and that was kind of his setup that he had to make the first EKG tracing. So yeah, you got this guy in Germany that developed it, and so he spelled electrocardiogram with a K, and that's where the EKG came from. So they're used interchangeably. There's no difference between the two. So our electrocardiographic monitoring, what we're going to be getting into, I'm sorry, he wasn't from Germany, I just had to look it up. Let's see here. He was Dutch. He was from Holland. My bad, guys. Anyway, but that's why it's spelled with a K. So, our electrocardiogram is looking at positive and negative impulses, and it's looking at the electrical conduction of the heart. Our electrocardiogram has no basis of, has no way of telling whether the heart is contracting or not. All it's able to do is tell us that we do have the electrical impulse that the patient's heart is demonstrating. So we have, in every EKG, we have positive and negative impulses. We have, based on our isoelectric line. It's important to remember as we start looking at these EKGs that we need to be able to determine what the actual tracing is showing and what's artifact. Artifact is just an interruption in the tracing caused by something other than the patient's bioelectrical impulse. It can be caused by muscle tremors, patient movement, inappropriately applied electrodes, shivering, and then occasionally, not real common anymore, but you can see what's called 60-cycle interference. There's a lot of things that can cause artifact. Sometimes they're easy to pick out, and sometimes it's not very easy to tell what's artifact and what's not. So here's an example of what our artifact looks like. At this point, this is the end of this PowerPoint. Whenever we come back, we're going to really get into the EKG interpretation and the basics of EKGs. So if you guys have any questions, feel free to contact me by phone or email. My phone number here is 620-870-0271. I'm more likely to respond to text message than if you call me. I don't really like talking on the phone. So if you have any questions, just hit me up and we'll get it figured out. So this concludes the first PowerPoint, and we will continue on with EKG interpretation. Okay, at this point, everybody go ahead and proceed to the first quiz. It's going to cover basically everything that we've covered in the first slide. It's just going to be a short little 10-question quiz, and see how you do. Thanks.